Hi, I'm Dr. Robert Silverman, Amazon best-selling author of Inside Out Health and host of Proven Health Alternatives. Today's episode has Dr. Erika Gray, co-founder of Toolbox Genomics. We talked all about different genomic testing. What is a genomic test? How it's different than a genetic test, how they mix lab tests in there, and how it can help you get a better health outcome.
Hi, Dr. Rob Silverman here, Proven Health Alternatives. I've got a great guest. I've got Dr. Erika Gray. Erika, how are you?
I'm doing well. How about yourself, Dr. Rob?
I'm doing great. So I'm really happy you could take some time. You're going to talk about genomic testing. I want to give everybody just a little background on you. I've got your very, very impressive CV here. So again, I've got Dr. Erika Gray, PharmD, which you can explain to everybody, co-founder of Toolbox Genomics, has a PharmD from the University of California at San Francisco, and you have worked as a pharmacist at a level 1 trauma center in both the inpatient pharmacy and emergency room. Your experiences in the emergency room of seeing the terrible manifestation of chronic diseases and in helping patients understand their biomarkers in relationship to their health paved the way for you being a co-founder of Toolbox Genomics.
That's right.
All right. Well, you know, that's an impressive CV. Tell everybody a little bit about those experiences and how you got here.
Yeah, absolutely. So my journey to become a pharmacist, a PharmD, doctor of pharmacy, really started when I was 16. I was diagnosed with endometriosis. And it was the failure of conventional medicine to really help me in that journey and getting introduced into the alternative medicine world, which we now call functional medicine, getting to that root cause and understanding the why of why I developed it and what were the different inputs from an environmental perspective that I was doing to myself to lead to endometriosis. And it was really that convergence for me, learning about bioidentical hormones, using it, that I said, I really want to help other people with this. And that's how I became a pharmacist and then went to UCSF.
Wow. You know, it's so funny that everybody in our field, you know, chiropractor, MD, PharmD, it's always something that happened in their life that changed them. And it's so compelling when everybody hears it because you know what they know? They know you're doing it because it's your mission.
Exactly.
Your job. And,
yeah, you care about it. You don't want other people to suffer with the same things that you did, or at least you want them to have the tools that you didn't have when you went through your experience.
Hence the word toolbox, I assume?
That is one of them, yes. We want you to have many tools in your toolbox of health, of how do you address, what are the different things you can do to help yourself?
Well, I'll ask the question two different ways. What is Toolbox Genomics? And if you could also, what is a genomic test?
Yes. So Toolbox Genomics is an end-to-end solution for healthcare practitioners. So from the kit and the test, all the way through to the reports, actionable recommendations in 4 different areas: diet, lifestyle, supplements. Further testing, just because you have the gene doesn't mean that you are expressing it. You may express it 10 years from now, but we need to get that idea of who you are. What is that blueprint? What does it look like? What's that trajectory of your health looking like?
And we always use the expression, I'm writing it down now, genes are not your destiny.
Genes are not your destiny. Yes, they're just a glimmer or a glimpse of what you could be, what you can be, both from a positive and a negative. And when I say a negative, I don't mean like this is a bad thing. It's something that's going to need more support. So when we talk about genomic testing, I'll get to your other question in a second, it's really what are the things that we need to pay attention to? So, you know, once upon a time, we used to go to AAA and get roadmaps, right, before Google. And now on Google, they'll tell you, hey, there's a slowdown up here, or there's potential hazard advisory. But we didn't have that when we had those paper maps, right? We just knew we were going on I-5, from Southern California to Northern California, but we didn't know what it looked like. And that's what our genomic tests will tell us. It will say, this is what it looks like for you, but we don't know what are the various inputs that are going to happen along the way. And that's where we're going to get to this in a second, but it's like Google Maps is like lab testing plus genetic testing. Genetic testing alone is just like that roadmap of who you are. And that's how you come together. So when we talk about, you had asked about genomic testing versus genetic testing. So genomics it's a whole new world when we're talking about omics, we're talking about 4 different areas. We talk about genomics, which is the interaction with your genes. We talk about transcriptomics, which is the copying of your DNA. Then we talk about proteomics, which is the proteins in your DNA. And we talk about metabolomics, and those are all those lab tests that you like to run on your patients. So those are the different areas that go under genomics.
And all of these are in your Toolbox Genomics.
Correct. Yes. So we go through, we don't talk about proteomics and we don't talk about transcriptomics, but we talk about your genomics and we talk about your metabolomics when we make recommendations about further lab testing. So that would be like a homocysteine level, a D3 level.
Outstanding. So why should practitioners use genetic testing? I mean, we just said before, genes are not your destiny.
Right.
Maybe I should also add that 70 to 90% of what the people out there, the patients, and I'm a doc, I'm still a patient, I have other docs, yes. 70, 90% is controllable. With that being said, why should we do genetic testing?
But it's nice to know what we really need to focus on versus things that we can maybe let go of or not worry about right today. So for example, my son has he's a carrier for one of the celiac genes. So I was able to point out to him, this is why it's important for you to avoid gluten. Because he would come to me and say, well, I think I'm doing fine. And then 2 days later he goes, oh, I had a slice of pizza and my stomach hurts. I said, this is why. So he said, so I really need to be more careful about this. And I said, yes, you do, because you have gluten every now and then. It's fine. You keep having the gluten. It's going to irritate that gene, so to speak, and cause it to affect you more profoundly. So the big thing is lab testing versus genetic testing, right? What's the why? Why should we do both? Why should we do one or the other? Lab testing is a moment in time. What is going on with your patient today? Genomic testing tells you about your patient's future. So it's really, really cool because you can take someone in their 20s and 30s and really set them up with a fabulous program that's unique to them. And it's going to be a lifetime intervention, not a moment in time intervention.
That is outstanding. So I really like what you said about your son, because being a practitioner, so many times basically everybody who walks in here, everybody goes gluten and dairy free. And you would understand why. But when I'm able to back it up with that marker and let them understand that they have a genetic propensity towards damage because of consumption of this horrible food, if you will. Gluten means glue. It sticks to your intestinal tract. It's great. Plus, when you think about it, for me, I'm a practitioner who loves baseline.
Yes.
So here's where we are, and here's where I want to take you. And I know that patients like that, and you're a scientist, here's where we are, here's where we want to go. So it looks like genomics, if I could say this, is the combination of genetic and lab testing together. Would that be a fair way?
Well, and the environment, right? Because it's also a ability for you to teach people what, actually, here's even a better example. So we always say everything in moderation, right?
Right.
And so this is how people justify various lifestyle decisions. But who's making that decision for moderation? It's your brain. So your brain is deciding what is moderate for you. And some people have looked at me and said 3 glasses of wine is moderate because I cut back from 6 glasses of wine. And I say, okay, but if you're an APOE 3-4, so you're a carrier, higher risk for Alzheimer's, we know alcohol adversely affects this gene. Oh, you're a slow alcohol metabolizer, so you're taxing your liver. 3 glasses of wine is not moderate for you. It's high. It's a problem. You need to have no alcohol. So this is where you can really be very, forceful is not the right word, but compelling for your patients and say, this is why I'm saying this, and this is why it's so important for you to adhere to this.
So therefore, it kind of goes into my second question, and I want to get to the APO4. We cannot let that slide. How can genetic testing change my treatment protocols or a doctor's treatment protocols? I think you just said it, because it's giving you a baseline and it's giving you a window inside to people's propensity. Would that be fair? And if so, I got to go for the APOE4. You brought it up.
Oh, yeah. We'll go there in a second. So, yes, it does. And actually, I had a webinar yesterday and I was talking about fatigue and this patient that I had. And one of the things was she was getting B12 shots. And I looked at her genomics, and sure enough, she had a bunch of markers for the B12 snips, including some of the transport snips as well. So that means getting the B12 from outside of the cell.
I'm so sorry. Define a SNP for our listeners.
Oh, yes. So it's a single nucleotide polymorphism. Massive mouthful to say. We call them SNPs. But what it is, it's a base pair change in your DNA. So your DNA, if we go back to high school biology, you've got base pairs. A matches with T, C matches with G. Well, evolutionary pressures have changed that. And so sometimes A matches with G. When you do that, you get a change in enzyme. You get a change in transportation. You get a change in the effect on the nucleus, when how hormones bind to receptors. It's supposed to happen. SNPs are what makes me, you, and all of us unique. And it's 1% of our genome.
So how important is it to know your SNPs?
Oh, I think it's life-changing, truly. I mean, because you can actually start thinking about what are the things you need to do. So if we go back to that patient for a second, she was getting B12 shots, but her B12 levels were over 2,000. Now, she said, well, I thought I was supposed to take B12 because I had low energy. It's like, yes, you did. But what was actually happening was that because she had an issue with her transporter genes and her transporter SNPs specifically, she wasn't getting the B12 into the cell. So she was getting this whopper of a dose through a shot, but it wasn't actually getting into the cells and doing what it needed to. So what we actually did was cut back on her B12 dose, cut back on the frequency to give the body time to get it into the cell, because she just couldn't handle it. And there was all this excess B12 floating around in her blood that wasn't doing anything. You need to get into the cell.
So basically, by taking the genomic toolbox test, you were able to make a more specific, individualized, personalized treatment program that increased the efficacy.
Exactly.
So you are, if we can use some layman's terms, you turned the lights on in the room and gave the sniper lens.
Yeah, that's exactly right. I liken it to taking a flashlight and shining it in those darkest corners of your room and discovering those things, it's like the money you forgot that you had or the clothes that you were looking for. It's all these little hidden gems that really are going to speak to who you are, what you can do, and what does that future life look like, and what are the potential supports that you need.
It's so funny, as a functional medicine, I like to call functional nutrition practitioner, that's what we're looking for. We are, without question, looking for those guidelines. We're looking for that baseline. What we're looking for is to get rid of those old antiquated lab tests that really don't tell us anything, that don't allow us to evaluate the body from the inside out. And with this genomic testing, again, it lets us to pinpoint specific things. So for instance, if we can continue to talk about your son who's got the celiac, everybody knows that he has a celiac marker. Celiac means that, you have an allergy to protein and gluten and wheat. That poses an issue. If someone has celiac disease, you have a higher incidence of leaky gut, all systemic inflammation, SIBO, and the like. With that being said, what about his SNPs? How is his SNPs looking because of that?
Yeah. So he was he's a carrier for it. So he is heterozygous for what we call the DQ8, for the HLA DQ8, and he's normal for the DQ 2.5. Now, that I know that's Greek to a lot of you, but
no limit on that, yeah.
So essentially what it is that when you eat gluten, it binds to these HLA little molecules, and it shows it up to your immune system. And so people with these genes, your immune system goes, hey, that's a problem. We're going to attack it. And what ends up happening is that it forms these antigens. And so when you eat gluten, it recognizes it as a bad thing. But a lot of these molecules also masquerade as, or very similar to organs in our body. So for example, the thyroid or kidneys. And so this is why a lot of people who have gluten sensitivity are going to have thyroid issues. They're going to have leaky gut, because the gluten is actually irritating your mucosal lining. And so those tight junctions that should be super tight are now getting weak. And then now you can allow those food particles to pass through. Now they're in the bloodstream. The immune system says, hold on a second. those aren't supposed to be there. So it's essentially what ends up happening is when you have that, you need to be aware of low-level inflammation that's in the body. And we know low-level inflammation is like that fire that's just burning in the background that won't go out. It's those coals. You can't see them, but they're hot. And they're causing a problem for your body because the immune system's constantly working with it.
Right. So what you described so ably was that leaky gut because of the marker can get caused. And the immune system comes and sees the antigen, something that's foreign, as foreign, starts to attack. So now you got low level, like you said, systemic inflammation. You can get localized in the joint inflammation, chiropractor. So, and you can get and lead to what we call autoimmunity. And
That's
autoimmunity
right.
is when the body attacks itself because it gets confused, and that's molecular mimicry. And that's all that we talk about on Proven Health Alternatives, because I am all about the gut, because 80% of your immune cells are in your gut. It's where your macro and micronutrients are absorbed. So now you are without question showing somebody the cascade that they may inevitably have, and we want to avoid that. So that
Exactly.
that is outstanding. What a great test.
And what ends up happening is my son gets a stuffy nose, low-level inflammation. So that's always my first cue. And so I'll say, did you have gluten yesterday? Oh, well, I just had a little bit. And it's like, okay, if you don't want the stuffy nose, you don't want the stomach cramps, this is what you got to do. Now, something important to say is that, as you mentioned, the gut is so vital for our micronutrients, neurotransmitters, really our entire well-being, because we have 3 to 5 pounds of bacteria in our gut. So when we take 5 billion colony-forming units, you're not touching those 3 to 5 pounds. Like, you got to put an elephant in there, right, to cause an effect. So high-dose probiotics can really be beneficial for people in helping to support some of these genes or food sensitivities. It's not always the answer, but for those people who, like, I think I can tolerate a little bit of it, probiotics are really going to be your friend in this, because they're going to help modulate so much in your gut.
Yes, because your probiotics are those good bacteria, and that will decrease dysbiosis. This is music to my ear and all the listeners here. That is outstanding. Here's what I want to ask you. I wrote this one down as you were talking. It's a great one. What is one thing you've discovered through genetic testing you wish everybody listening would know? Give me the one. The one Monday morning test.
APOE. I mean, my father's a carrier, and so it really was so helpful for me to learn about that, because then I actually had something with really strong evidence to go to him and start impacting behavior change and impacting lifestyle change. And I mean, to this day, I remind him, hey, if you have another glass of wine, your brain already isn't, has a different composition than somebody who's a 3-3. I mean, they've shown that from birth.
Now,
And
APOE4 is a cholesterol.
A 4, yeah. So the actual brain structure is different from a 3.
Okay, so APO is a cholesterol.
It's a cholesterol. It's a transporter protein.
Right. So we've got the APO, there's an APOB and an A that everybody talks about. The B is bad, the A is good. There's an APOE, we got a 2, 3, and a 4.
That's right.
So why don't you go through those for us? Because people find it very interesting.
So essentially there's 2 genes that play into this. But when you are what we call a 4-4, we're only looking at one of the genes. And what it is that your cholesterol transporter system isn't as robust as somebody who's what we would call a 3-3 or a 2-2. So the brain needs lots and lots of cholesterol. That is how it lives and exists. But this transporter system is broken, and it's specifically for LDL. So what ends up happening is like your brain is almost starving for these nutrients through the cholesterol. But the other problem is because it's not getting to where it needs to be, they tend to have higher cholesterol levels, higher LDL. They don't respond to statins as well. So it's an important opportunity for us as practitioners. You see someone is a 4-4 or a 3-4, and they say, hey, my doctor wants to put me on statins. They may not respond as well. So that's a really great opportunity for an intervention for us, right?
APOE4 is the marker that everybody should sweat if they have. I think correct me if I'm wrong, about 25 to 30% of the population has it. And what you're saying is it allows for adverse plaquing in the brain, hence leading you down a path of high susceptibility to Alzheimer's. So when I tell people if they have an APO4, you should start your Alzheimer's protocol right now.
Right now, yep.
If you have APOE2, you start yesterday.
Yes. Well, no. APOE2 is different because their transporter system is really, really good. So they're at a much lower risk for Alzheimer's. So they actually are at a higher risk for MS, right? The myelin sheaths in the brain, they need more fat. So those are people who do not want to avoid fat in their diet. They really want some good monosaturated fats because their transport system is so good. It's just moving it all throughout the body, getting it into all of the cells, but they may need a higher level. So some people who are 2-2s may even do well with a keto diet as well. I mean, you've got to look at other markers too.
APOE2.
Yep.
MS. High fat diet. APOE4.
Low fat.
Alzheimer's. Plant-based.
Plant-based, low monosaturated fat diet. So again, the saturated fats for that group is not going to work well. The monosaturated fats are fine, but coconut oil has not been shown to be beneficial for the 3-4 for a 4. If you are a 4 carrier, it doesn't show a benefit. If you're a 3, it does. So it's really interesting because we talk about ketone bodies, we talk about coconut oil for the brain, but not if you're a 4.
Right. It's the other 75% of the people. So 3 out of 4, and that's great because well, one, we're going to also cover APO3. But what does that say? Everybody says, well, what diet should I go on? Well, what's diet is right for you? We need to test to see your susceptibility because you and I may eat broccoli and it may do one thing for you and something different for me. And there was just a study that just came out on that. It was fascinating in that they said that your gut determines so much, and the difference, what you and I eat, it doesn't affect our guts in the same manner. The only thing they knew is we all should eat whole, healthy foods, and we need to keep our gut health. And they should have said, which they didn't, but we'll say it here, they need to test. APOE3. Tell them about that.
Yeah, so APOE3 is considered the average or the normal. So you have an average risk for Alzheimer's. It's about 60% of the population. This is where most people are going to live. And those people, you don't have the same restrictions based on the APOE status as you would if you're a 4. So those people can handle the saturated fats. You're not going to see as much of an impact with alcohol or exercise for this gene. So I just want to be very, very careful that people don't go, hey, I'm a 3-3. I can go drink. I don't have to exercise. There's so many other things that come into play. And we have to remember that every glass of wine causes oxidative stress. And your liver, if it's not doing its job, if you don't have the genes to make glutathione and do your phase 1 and phase 2 metabolism, that's a whole nother story. So it's just, I'm just trying to make the contrast between a 3 and a 4 and how there's lifestyle differences specifically for that gene.
Right. I think the wine companies have done a great job saying that a few glasses of wine are healthy. I always ask people, do you drink? And they say socially. And I always ask them, how social are they? Yeah.
That's a good question.
Night, you're a little too social.
Yeah. And then, so if we go to the chews, right?
Mm-hmm.
The chews are very rare. You don't see them often. Every now and then you will see a 2 and a 4. Very rare, but the 4 is just so much more of a concerning issue, so you would treat them as a 4. But the 2s, again, the higher fat diet, and you just want to monitor their lab work, their lipid levels, and also you need to look at other markers. How do they handle saturated fats? How do they handle other fats? How do they handle proteins? Because that's going to give you a better suggestion of how to help support their dietary needs.
That is without question. The APOE4 will be the conversation piece that everybody has, and that's exactly where I wanted to go. There would have been a few others I would have asked, but that's the one. So what are the most common misconceptions relative to taking a DNA test, like a self-test kit and stuff? A lot of people don't understand that.
So they think that, well, I should specify too, sometimes it's company specific, right? So they think if you do a DNA test, you are going to sell your data, right? You're going to sell it to pharma. So that is company specific. We do not do that. We don't do anything with your data. You give us a test and it goes into a black box, and that's where it stays, so to speak. People think that you have to retest your DNA. So they think you do it once, you do some interventions, and then you retest again. You don't, because these are the genes you're born with. It's the expression of it that changes. So it's the expression that we measure. We look at how they look at physiologically. We look at what they call the phenotype, what we can see, what we can measure. And I think the other one is that, as you said earlier, oh shoot, these are my genes, I'm doomed. I might as well just live life to the fullest because I just got the crappy set of genes. And that is so far from the truth. It really, really is important to know that you can positively impact it. And I think the important distinction to also make is that what we're looking at are predispositions to diseases or nutrient deficiencies or how we metabolize our food. We don't test for carrier diseases such as cystic fibrosis or some of these, what we call an autosomal dominant condition like Huntington's. Those need to be done at a diagnostic DNA test. Same thing with the BRCA test. It's really important that you are going to go and get that test done with that type of company. So we are just doing what we would call more of a screening test. So that's an important misconception that people don't realize, because they'll think, well, I just did a DNA test and you test for everything. No, you don't. You test for very specific things, and that's company specific. And we're looking at those predispositions and the nutrient deficiency.
Outstanding. So I want to do a little rapid fire panel with you now, because as we get towards the finish line. So you have a cardiometabolic health panel. What's it?
Yes. So we've got lipid dysregulation, blood sugar, coronary artery disease, metabolic syndrome. I should also say for the dyslipidemia, we've got LP(a) in there. It's a lot, it's a big marker.
What a genetic marker. So wait, you mean it's just not HDL, LDL, and total cholesterol anymore?
No,
I was trying to be a little acerbic with that. That's what I see a lot of. And we need to break down into particle sizes and the predisposition on who's susceptible to that. That's great. Immune panel.
Immune. So we've got MS, we've got inflammation, oxidative stress, psoriasis, Hashimoto's. And so those are going to be the ones that are going to cross over very potentially for people who have food sensitivities, as well as into the fatigue panel as well, just because there's a lot of immune inputs that go into the immune panel because we're looking at autoimmune conditions.
Outstanding. A detox panel.
This is our favorite one, right? So there's a lot of genes that control our ability to detoxify within the environment or the foods that we, or even our own byproducts that we make. So like hormones, our body has to detoxify and break those down. So we look at glutathione, we look at heat shock protein, MTHFR, everybody's favorite, SLT, COMT, all of the different CYP enzymes that are going to play into drug metabolism. We've got the SUOX gene as well. So it's going to look at sulfite. So there's a whole bunch of them that's going to really help you understand how does your patient handle the environment, either what is they're coming into contact with, or what is going on internally as well.
All right, we can't let you leave. You said it, MTHFR. Go for it.
All right, so it stands for methyl tetrahydrofolate reductase. All of that means it takes this one form of folic acid and it converts into the active form, which lets it into the cell. So when we talk a lot about these different nutrients, they need to get into the cell. If they are outside of the cell, they're not doing what they need to do. They're not supporting the body. They're not helping your mitochondria. They need to get in. This enzyme helps folate get into the cell. And what happens is that if you have the gene and you code for a sluggish enzyme, it's not getting the folate into the cells fast enough. So all of these cells that depend on folate to help you make melatonin, to make neurotransmitters, to make tetrahydrobiopterin, which is a big detox pathway, it doesn't happen. You can't recycle homocysteine back into methionine. Homocysteine is inflammatory. So that's why folate is such a big deal. It plays a role in detox as well. But I want to highlight, it's one gene. That's it. There are lots of other ones. There has a lot of supporting staff. It's like the Kardashians, right? It's an influencer. Everyone cares about it. But let's think about the entourage that follows the Kardashians around. It's the same thing with MTHFR. There's a lot of other stuff.
You are speaking to the choir. I love it. So wait a minute. So I will have this conversation with a lot of people. Hopefully I don't get beat up. So essentially, if you take methylated B vitamins, you've got the answer for that reductase problem, correct? The answer at that level.
Right.
Now let's piggyback on what you said. Now that we've covered that problem, now we have to see all the collateral damage that it covered.
Correct.
That's what I want everybody to get to. Because we lecture, that's what we talk about. We can solve that problem.
Yep.
But we have to look at the
whole picture.
Yeah, there we go. That's great.
So as a side note, people say, what is my MTHFR status, right? Their entire life depends on it. And heaven forbid they're homozygous for the risk for C677T. But did you know that riboflavin is the vitamin that helps stabilize the gene? So maybe they have a riboflavin deficiency, not a folate deficiency. But we're not talking about that.
Yeah, that's a teaser for another time. That is great. So I wanted everybody to know that I'm involved with Toolbox Genomics, and we're going to do a part 2 to this. We're going to kind of switch roles. Erika's going to kind of talk with me and kind of quiz me a little bit because we've got a panel coming out, Dr. Rob panel, a couple of things that are real important to me, like gut to brain, TBI concussion, and musculoskeletal. So we'll be doing that one in about a month from the time this one airs. So, Dr. Gray, this has been great. I wish we could spend more time, and I think we're going to spend a lot of time off. Anybody needs to get in touch with you or Toolbox Genomics, how can you do it?
Toolboxgenomics.com. Any questions, if you want to get signed up with us, we've got a great onboarding program. Email us at info@toolboxgenomics.com, and that's all spelled out. So TOOLBOXGENOMICS.com.
You want to share your personal handle, so if they want to follow you, they can?
Sure. So it's Erika at toolboxgenomics.com. If you want to email me personally, you can also find me on LinkedIn as well.
Outstanding. I got Dr. Erika Gray, Dr. Rob Silverman, Proof in Health Alternatives. Always yours in health.